Hey everyone, it's just turned 6 o'clock, so we'll get going. Good to see a few familiar faces there. Hi Mark, hi Peter. How are you both? So this is day 2 of week 6, and we've got a lower back presentation this week. So we've obviously been doing this for quite a few weeks now, and the whole idea with this is to no worries, Mark. You're welcome. The whole idea with this is to get you thinking about other things other than musculoskeletal presentations. And we focused a lot on tissue issues, basically. So diseases and fractures and problems with the blood supply and all that kind of stuff. But sometimes there's a psychosocial element to the presentation, so that there isn't with the, well, there are some things with this particular one, but I just wanted to delve into that in a little bit more detail. Good. Yeah, Mark's just said could even read my writing. Yeah, sorry about that. Typical medical professional, my writing's terrible. Okay, so yeah, we're going to delve into that in a little bit more detail and explain the pain neuroscience education side of I know. Well, I kind of I don't know, embraced it, like you said, Peter. Yeah, embraced there. It might end up like a bit of an afro in a couple of weeks' time, I think. So yeah, that's going to be a bit of the focus today. So most of you guys know me, so we'll skip over that anyway. And just to let you know, if you haven't heard already, we are doing a live course next Monday is starting. So we're going to do Monday, Tuesday, and then the following Monday and Tuesday. And it is the functional movement taping 1. So it is the exactly same qualification that you would get if you did an attendance course. Hi, John. And yeah, so we're going to run it online, and we've created a Facebook group for people to join who are on the course, so that we can assess your taping techniques and you submit videos and stuff like that. So if you fancy that, I've just popped a link up for that there. I think we're only allowing 15 people on the course to make sure that we keep the numbers manageable. And I think already 8 or 9 places have gone. So that's really good. So if you fancy doing that, if you've not done it before, then feel free to jump on that. So wanted to go into this in a little bit more detail. So looking at pain neuroscience education and our current presentation as well. So this the lower back patient. So I've got a video coming up in a second, and I'm going to play it for a minute. And what I would like you to do is in the chat box, pop down all of the key information from that 1 minute of case history taking. Okay, so we're going to come up with that we're going to do that in a second. But what I wanted to get across to you is, yes, we've been dealing with a lot of pathology over the last few weeks. Sometimes obviously that's really important to know, and you have to have that in the back of your mind. It's very unlikely that you will get case scenarios like the ones that we've done. They're very unusual, and some of the pathologies that they've had have been quite rare. So they're designed to get you thinking. That's exactly what they're designed for. But with that in your back of your mind now, and all that kind of worrying about their problems with their health in general, we then sometimes forget the easy stuff as well. We forget the fact that I don't know, they may have slipped over, or you know, they've just sprained their ankle, or whatever it is. You know, it could be something really, really simple, but also there could be a psychological element to their presentation as well. So we've got this balancing act going on all the time. Well, they're saying this one thing and it's this. And that's, as you get more experience, you then start to question those things, because you want to get to the bottom. Well, is it the pathology, or is it something else? Is it to do with their psychology that's affecting their symptoms? And you learn the kind of layering of of questioning to find out exactly what to focus on, or whether to refer that person. Okay, so it is a balancing act all the time, and in your head you'll have a million thoughts going on about what could be going on with the particular person. So I'm going to show you this video. I'm going to play it for 1 minute, and that's it. Okay, well, it's maybe about 1 minute 20 seconds, but it's a chap called Peter O'Sullivan, and this clip is available on YouTube, so you can watch it on YouTube as well after this. But what I'd like you to do is listen to what they're saying, and I'd like you to in the chat box pop down any key information that you think is relevant for this particular chap. And his name's Jack, and he's got a bad back. Okay, so it's linked in with the case history that we're doing today, but there's a different outcome with this one. Okay, so just wanted to explore this. So I'm going to play this for you. So just a minute, and then jot some information down in the chat box.
When I saw you about a year ago, and you came in and you were in a fair bit of trouble.
Yeah.
What was going on for you then?
I just stopped work. I'd been having this pain for about 4 or 5 years. Quit my job from manual job to working in an office. Got to a point where I couldn't even sit on a chair no more.
And you were planning on being a footballer,
Yeah,
right? That was like your dream, yeah.
I stopped football. Had MRI scans done back a couple of years after that. And got told I had to have an operation. Because it was my lower disc, I had to go through the front. Might not be able to have kids. Now, all this sort of scary stuff. I got told they hadn't seen this in a young man. It was like I had the back of a 70-year-old. That's what I was told.
Yeah. So let's just have a look at some of the things that you were doing when you were moving. Can you pick that up for me? Can you place it down here? Same way. Did you hold your breath?
Yeah.
You did, didn't you? Okay, just turn around so you're facing this way. Can you do that again? You were very, very guarded, and you thought you were going to do some major harm by moving. And I was quite persistent with you, making you move. And you weren't quite sure that was such a good idea at the time, I think.
No, of course not, because when I've done it before, it was hurting me.
So what would you think would happen if I got you to relax over and pick it up? What do you reckon would happen?
I can't think I'll get back up.
No? What, you think you'd be stuck?
No, I could, but I just want to get back up that way.
We took you through a bit of a sequence of trying to get you to bend, and you were quite resistant to that. So I tried to relax you lying down. You didn't like me bringing your knee up to your chest. I tried to get you to roll your pelvis. You didn't really like that either. I looked at how you were rolling over. You didn't really like that too much either. And then I had you on the hands and knees. What's this doing? It's illegal. Yeah, but you say it hurts, right? Do it again. Tell me when it hurts.
It hurts in this position, no?
Okay, so well done, guys. Yes, so he was a few things that you've picked up there. So he was scared about moving, definitely fear of movement. And I asked the question, why was he scared? And so you saw his MRI scan that he had done at the hospital. Really good, Becky. Well picked up. Yeah, so no longer had the chance of pro football, and possibly not able to have kids either. So he was told that because of the state of his back, he had the back of a 70-year-old, that they may have to operate on him, and the operation involved going in through the front. So that may affect his chance of having children. Okay, so he was told quite a lot of very negative information. So yeah, back of a 70-year-old, which scared him into moving, and then possibly thinking that he was going to cause more permanent damage to the spine. Yeah, lots of negativity about his issue. And what you'll notice with what Peter O'Sullivan did, he got him to pick up a pen from the floor. And whenever you examine anybody, exactly. There are some really interesting things that medical professionals often say to patients. You've got to be really careful what you say, because that momentary lapse, or even maybe not even a lapse, maybe it's something that you believe as a medical professional, but that instant will last for years. And that single comment that was told to him, I mean, how long did it take for him to say that? Maybe 5 seconds, and that has stayed with him for years. Yeah, so you've got to be so careful when you're talking to people. Yeah, really good, Catherine. Yeah, so he's protecting his spine, but not bending. So what Peter did, I mean, when we learn active, passive ranges of motion, when we're doing lumbar spine assessments, you get someone standing and they're stood in the kind of anatomical position. And we used to teach this at uni, you know, we used to make the students get their clients to stand in anatomical position. It's the most unnatural position to be in ever. So you want to see people moving in their natural environment. So dropping a pen on the floor and asking them to pick it up, or watching them do up their shoelaces, or whatever it is that, you know, the task that they can't do, we want to see those tasks. And things like picking up a pen off the floor, you shouldn't have to bend your knees. Yeah, you should be able to just roll over and just pick up the pen. Yeah, you're not lifting 120 kilos on a deadlift. Yeah, so really good, Stevie. Yeah, so everything he was doing was very protective. So what Peter was then trying to do is reduce the protection, yeah, of that region. And it's no wonder he was protected, because he was told that he had the back of a 70-year-old and he had all these thoughts of the problems with his back. Okay, so it's a really important message with the information that you're and the words you use, the things you say with patients, especially with backs, because we get a bad back often as often as you would get a headache. Yeah, so I mean, obviously it differs from person to person, but for someone who's got a headache, you wouldn't say, you know, oh yeah, you've got the brain of a 70-year-old or whatever, and that's why you're getting headaches. It's just crazy. You know, we protect the back for some reason within our kind of profession, and that message then is passed then down to patients, and it's really difficult to allow that person to gain the trust in using their back again. Okay, so they're definitely linked into our case study. Just going to go back to the slides. I wanted to show you this because this links into this case. So the chap who was just on the video, he was shown an MRI which showed changes in his spine. Yeah, he looked around about 30, I would guess. Okay, so if we have a look at this, so this is a systematic review that was done in 2014, and this is a review of imaging features of spinal degeneration in asymptomatic populations. So these are people with no pain. Okay, they don't have any problems with pain. Okay, and the imaging findings of spine degeneration are present in a high proportions of asymptomatic individuals, and it increases with age. So as you get older, you have changes in your spine. It is normal. Yeah, these people had no pain. They didn't have any problems. So this is the issue. Okay, so you say, oh, I've got a problem in my back. It doesn't really resolve. So then the GP sends you for an MRI scan. If you're 40, guess what it's going to show? It's going to show that there are changes in your spine, but everybody's got changes in their spine. So are they relevant issues, or are they just signs of the normal signs of aging? Then the report comes back and it says things like degenerative disc disease. And it talks about prolapses and herniations, which is true medical terminology, but it's not telling the whole picture, because everybody would have those, or the large majority of people will have those problems, in inverted commas, problems. So many imaging-based degenerative features are likely part of normal aging and unassociated with pain. Okay, and this is a nice little graph or table for that. So disc degeneration, which is one of the things that is usually commented on an MRI report, if you have a look for 30-year-olds, half of 30-year-olds have disc degeneration. Yeah, so if you send someone for an MRI who's got back pain, 50-50, they are going to have some changes in their spine. Will that get blamed for the pain? Potentially. Okay. And maybe it shouldn't be. It obviously there's part of a bigger clinical picture, but just the imaging, just the changes in the MRI does not mean that there is going to be any pain. Okay. It's that there may be none at all. And then obviously as you get older, if you're in your 80s, 96% of 80-year-olds had some kind of degeneration in their discs. So again, I mean, you wouldn't tend to MRI people that old unless there were other problems going on. But if you're sent for imaging and then you're told that you've got these issues with your back, that can be really, really damaging to your mental state. Okay, and what it does is it makes you very, very protective of that region. So then you don't move properly. Okay, and that was the problem that was going on with Jack. What happens with the rest of that video, you guys could, if you search Jack's back and Peter O'Sullivan, you can watch the whole thing. And he gets him to move in the end. He manages to get him to relax and bend. And bearing in mind, he's had back pain for 4 or 5 years, and it goes overnight. Yeah, the changes are astonishing. 58 years old, Stevie. Yeah, that's it. So but do you have any pain, Steve? That's the thing. Do you have any pain? But it's okay, just below. Yeah, exactly. Yeah. So if you the patients get annoyed as well when then their GP refuses an MRI, and they don't often need one. And this is why, because they can do more harm than good. Unless there are clear clinical signs that there is some pathology that may be detrimental to their health, they will not MRI these patients. Okay. And that's it. Brilliant, Stevie. Yeah. So yeah, perfect. And something that Claire Minshall said, she does these strength and conditioning courses for rehab, which are really good. And she was talking about this is the scaffold, this is the structure, and what we can focus on, what we can change is the scaffolding. So we can really help the muscles. Yeah, we can help on muscular endurance, muscular strength, creating rate of force development, whatever it is that person needs. So if we can support the structure with good scaffolding, then their quality of life will improve, their function will improve. And as that improves, then pain usually eases off. It depends on the person, but usually that will ease. Okay. So just wanted to throw that in there, that sometimes it's not, the pain doesn't have to be pathological. It doesn't have to be for some kind of damage to something. Okay, it can be because of the things that you're told or the things you believe, and that's the psychosocial bit of the sieve. Okay, that's really important. So hopefully that's helped. Yeah, brilliant, Peter. Yeah, so increase or sustained density of bones. Yeah, obviously depending on age and if you've got any other kind of clinical conditions, but yes, absolutely. But this is an interesting one. So quite often, and again, I'm not GP bashing, but this is what I've heard before, that they will often recommend things like yoga, Pilates, and swimming, cycling, that kind of thing. Yeah, because of the low impact nature. But the low impact nature of those activities means that it doesn't stimulate the bone density. Okay, so if we want that osteoblast activity, we need to stress the tissue and we need to stress the bone, but that needs to be done in a graded way as well. Okay, so there are loads of caveats, but yeah, again, you've got to choose the right exercise for the right person as well. Okay, really good stuff, guys. Okay, so we're going to get back on track, back to our case. So gone through the first appointment. We're into objective assessment planning, so we're going to go through that sieve at the moment, and looking at the lower back scenario. There's your sieve. Let me just pop that up if you've not seen that before. There you go. So that's the sieve if you want to download that if you've not seen it before. And this is Gary. So this is just a bit of a summary, picking out the key points. Okay, so he's 55 years old. So what kind of conditions do 55-year-old men are more likely to have? Okay, what kind of conditions may they suffer with? He's 5'8" and 14 stone. So he's overweight if you have a look at the NHS BMI calculator. And he does well from his history. He doesn't really do much exercise. So he's a heavy goods vehicle driver, and he's done that for over 30 years. All right. He's a heavy smoker and drinks whiskey most nights at the poker club. Yeah. So obviously that's not good for your health. But if he's drinking whiskey most nights, how late is he drinking that whiskey? And then how early is he driving his vehicle in the morning as well? So there may be some other issues going on there. He's divorced, has no kids. Okay, so does that change the psychology of things as well? Okay, I've worked with a heavy goods vehicle driver before, and he'd had a heart attack, and we were looking at putting a rehab program together with him, and he was only motivated because he was going to lose his license. He wasn't motivated for health reasons at all. It was all to do with his license. Okay, so different people have different focuses, and you need to tap into whatever those things are. Cool. So we've got lumbar spine, thigh, and pelvis pain. Right side worse than the left. He's had leg muscle cramping for the last 2 years, and he's had 10 years of stiffness in his lumbar spine. Okay, that so it would have started when he was 45, and remember, he's been a truck driver for the last 30 years. So is that a pathological thing? Is it some kind of red flag thing, or is it some kind of changes over time issue? Okay, so for the last 6 months, he's had pain and burning into both ankles and the low tibia area, and he thinks they are itchy. So what causes your legs to itch? This is when things started with his back. So he slammed against a wall, hitting the right side of his pelvis and lower back. Okay, and he was lifting some heavy goods. It was a really heavy crate of goods that he was having to try to move. Okay, so that's fallen on him, and then he's landed on his right side against the wall. Okay, so what kind of things can happen there when that kind of mechanism of injury is coming about? So we've got a daily pattern. Symptoms in the leg, pelvis, and lumbar spine have been getting worse each day since the accident. Okay, and he again really stiff in the morning for the last 10 years. So he usually works every hour he is allowed to, and sometimes more. Okay, so driving around, and again linking back into the drinking and stuff. So maybe that's a little bit of a yellow flag. Bunk bed of his lorry. He's sleeping in on long journeys. It sounds as if he's doing that quite a lot. He's divorced, so he's got no one to go back home to. Okay. Activity seems to make all of the leg and pelvic symptoms exacerbate. Okay, so activity is making it worse. It's worse going up the stairs, and the pain is worse in the anterior right thigh, so on the right side of that leg. Resting helps. Yeah, that's a really good sign, because normally we've had on the last OSCEs, the resting hasn't helped. Now with musculoskeletal problems, usually if you rest, it gets better. It gets a bit better, yeah, and it feels a bit better. So resting is helping, so that's good. He doesn't trust doctors. Okay, and in order to keep his, he goes every few years in order to keep his heavy goods vehicle license. Okay, so again, the motivation for his health is not to do with his health, it's to do with his job. So his job means a lot to him. Okay, he suffered from urinary urgency for the last 10 years. So he's 55, he smokes and he drinks a lot. He sounds as if he's not got a very good lifestyle, and he's having problems with passing urine. What does all that kind of add up to? Yeah, what might that be? Okay, so we've got persistent cough for 6 months. Again, what could that be? So there was an advert campaign a few years ago talking about persistent coughs. So if you've, I mean, that was just 2 weeks, let alone 6 months. Yeah. So if you've had this cough for 6 months, what could that be? He's been getting rather breathless. He's been suffering from palpitations, anxiety, and panic attacks for the last 2 months. Okay. And he's had some family history problems of a heart problem, and his mum had ovarian cancer. All right, so we've got cancer history, cardiovascular problems in the family history as well. And then since the accident, Gary has felt constipated. So he's had changes in his bowel habits. Okay, so that's some of the key points going over again. So this is the start of my sieve. Yeah, really good. Well done, Namir. Yeah, so we've got possible lung cancer and COPD. Yeah, really good. So I've listed a couple of just broad topics on the left there. So we've got cardiovascular disease. So why, what in the history indicates it, cancer as well. So why, what in the history indicates that, and where might the cancer be? Okay. COPD again, why? Diabetes. Okay. What is it? What causes it? And what are the symptoms of that? And then musculoskeletal injury. Let's strip all the horrible stuff out of the way. Risk of prostate. Yeah, really good, Brecky. Well done. Yeah, potentially. That's a real good one. So musculoskeletal injury. What might he have injured? Because remember, he's come to you because something's fallen on him off his lorry and he smacked his back against the wall. Okay. Yeah, mechanism and why. Yeah, really good. So those are the things that I want you to focus on between now and Friday. I was asked as well, oh yeah, let me just share you this. So just sharing another document there. That is the paper from the study that I showed you at the beginning. Okay, so that you can download that if you want to. Yeah, potentially, John, really good. Yeah, very good. There are so many things he could have injured with that fall. Yeah, hopefully you really want to ask him some more questions. I mean, obviously we can't, but it would be really useful if we could ask him some more questions there. I just want to share this with you as well. So Peter the other day wanted to have a look at the form I use. So this is the sieve. We do this electronically now. Yeah, good, Natalie. Yeah, kidney. Yeah, really good. That might be an issue, definitely. So we've what other things might you see with an injury to the kidney as well? That's really good. This is what I used to use on my sports massage course when we used to teach it a while ago. So what I did was I split that whole differential diagnosis book that I've been talking about for a little while. I split the whole book into one page. Okay. So what I did was I tried to look at the questions. Yeah, really good, Natalie. Very good. I tried to look at the questions that related that were replicated quite a few times. Okay, so we've got general questions here. So that any fever, chills, sweating, fatigue, weakness, that kind of thing, and they go through the list. If it's something to do with their skin, hair, or nails, then it's lumped into that section there. Okay, if it's musculoskeletal or neurologic, then it's in that section there. If it's a rheumatological condition, it's those kind of things. If it's a liver problem, it's those kind of things. Okay. And this is what's in that book, that differential diagnosis book. And I've just made it into one page. Hematological issues, so bleeding issues, blood issues, cardiovascular problems, pulmonary issues. So obviously I don't have the headings when we give this out to patients because I don't want to scare the bejesus out of them. But we would ask all of these questions. Yeah, and now we do it online. So we do an online form, and this is basically the sieve. Yeah, so we send this out. It goes through everything, and if what I say to my guys who work in clinic, if any two of those boxes are ticked in the same box, so these big squares here rather than these boxes here, then you need to consider a referral. So within our clinic, you could ask one of the physios or osteos or whoever who's clinically trained for advice, and then we would then help the guys write a letter to the GP. If you're working on your own, then if I would say, if two of those are ticked, then they're gone, and they're referred for further investigation. So that's when they don't know that something's wrong, and then you've got all the usual kind of, I know this has happened to me, so red and yellow. And then again, obviously with a patient form, we take the colours out, because if they're ticking the boxes that are red, then obviously that's going to freak them out as well. And then one of the key things, just go back up to the beginning. So one of our very first questions is, what do you want to get out of today? I think that's one of the most important questions you can ask. So you need to work out why are they there, what's the importance of them being there, and what do they want to leave with. So if you have an idea of the treatment plan you want to do and you haven't actually asked them what they're expecting, the two might not match. And if the two don't match, they're never coming back. Even if you did the best treatment in the world, they may never come back. So you need to ask them what they expect to get, what do they want to leave with by the end of the day, and they will give you really key information. Usually, sometimes they say, well, that's why I'm here, because I need your advice and I don't know what I want, which is fine. But quite often they'll have a clear idea about what they want to get out of that session. Okay, so I'll show you bits of this as we go through, because it's too much to go through in one session, but I'll do a little bit more on Friday and show you the other bits of the form as well. It's nothing, groundbreaking. It's it's just a very comprehensive checklist. That's all. Okay, so nothing crazy. Right, just jump off of that. Just go back to the presentation a sec. Okay, cool. So that's it for today. So I'll pop the what I've done now is I've created a YouTube playlist for all of these videos so that you can find them more easily, and I'll upload this probably tomorrow morning now. Try and do it before lunchtime the following day if I can. And so if you want to watch over the video again, go through the case history in the Facebook group, pop any ideas that you've got in there. Quite happy to take emails. I know a few of you have sent me messages as well, so that's really good. Aren't people put off your treatments because of the questions? I don't think so. What do you mean, Peter? Be interesting to find out what you mean. Do you mean because there's quite a few of them, or the kind of questions that we're asking? So if you want to reread the case history, pick out any key bits of information from there, try and build a picture about that person's health and what can be going on, and remember the anatomy that we discussed on the first. Okay, both. So I have had, so I ask about operations, and because that's just standard, and I've had someone say it's none of my business. So but these questions are often done before they come into clinic. So because I was on the phone to them and going through the after they'd filled in the questions, because they'd left some of them blank or put not applicable. So I phoned them up and I said, well, why aren't these applicable? And they said, none of your business. And I said, well, I'm really sorry, but I'm not going to be able to treat you because I need a thorough case history. So unless you want to fill in the form, I'm afraid you're going to have to find someone else. But that's been one person out of nearly 15 years. And then the other one's about especially about sexual function, that kind of thing. Those kind of questions, one of the reasons that we email it to people is because it's a bit embarrassing to ask those kind of things. I'm not embarrassed by it. I don't mind asking, but some people are embarrassed to answer the question because they're not expecting that kind of level of questioning, I guess, from, I don't know, manual therapy. I think if they went to the doctor, they would expect that level of questioning, but I think they've got a different perception of physio and osteo sports therapy. I don't think they would expect to be asked those questions. So yeah, one of the reasons we did it as an online questionnaire was to get over that embarrassment for them to answer it. But we've not had anybody not fill in the forms. Yeah, so it's and we've caught a couple of problems as well, and they've been really glad that we've asked the questions. They've actually said thank you, that we were so thorough, and I think as well that when you do an assessment like this, it's part of the treatment. That questioning, that level of detail, is part of them respecting you and your and what you can do for them. Yeah, so I think it goes hand in hand. Of course, you can't please everyone, but it's been minimal. I've had minimal problems filling in those. All of our documentation for a first appointment altogether is about 11 pages. So we do a thorough assessment on people, and but we try and get a lot of it done before they come in. So a good 4 or 5 pages of that is done in the comfort of their own home before they come for their appointment. Okay, so I think if you can get it done before, then it saves you loads of hassles. Are the forms encrypted? Yeah, so we use a software that is protected, so that we've got all their information encrypted. Yeah, you can use things like Clinico as well. There's software out there, but for clinic use. But yeah, it's all encrypted. We're actually just in talks at the moment with personal training groups, because obviously they deal with people with clinical conditions, exactly the same kind of things that we're talking about here. And we're looking at providing safety nets for personal trainers. So if their clients answer yes to those questions, then they get an appointment with a clinician before they go back to the personal trainer. So again, it's that another level of detail. I remember when I was a PT years ago, and there was a guy that this is how long ago it was. It was like 95, 96, and we had to, as part of the gym induction, do blood pressure monitoring. So I did this guy's blood pressure, and it was through the roof. And so I didn't mention anything, and then so I just got him to stay seated there for a bit more, and then we did it again, through the roof still. Did it a third time and just said, we do this 3 times anyway and take an average. And again, it was through the roof. So I was like, look, and this was his first appointment. I was like, I'm really sorry, but I'm afraid you're not going to be able to go into the gym today. And he absolutely went mental, completely kicked off, and stormed out. And but then the next day got an appointment with his GP and was immediately put on medication. And he came in about a week later to apologize about the way that he reacted. And he was really grateful that I didn't let him train that day. Okay, so sometimes people can be a right pain, but you're only trying to look out for them. Okay, so yeah, there's I've not had very many like that, but sometimes you've just got to stick to your guns, and because if that guy had trained that day, well, God knows what could have happened to him. So yeah, that's what the forms are there for, isn't it? So cool. Hopefully you found that session useful. I'll go through a little bit more of my form on Friday, and we'll wrap up what's wrong with Gary as well on Friday. Okay. Well done, everyone. Really good questions. Cheers, guys.